Morning everyone. Today my topic is abnormal labor and dystocia. Coming to the definition, abnormal labor means difficult labor characterized by abnormally slow progression of labor. Dystocia means difficult labor. It is most common cause for cesarean sections, that too in the primaries. It is more common in first pregnancies compared to second and third pregnancies. It is in 25 to 30% in primaries and 10 to 50%, 15% in the second and third gravida. Etiology, abnormal labor. The etiology, it consists of three P's: power, passenger, and passage. Power is for the baby to come out. The mother needs to have good uterine contractions and good maternal efforts. She should bear down well. That constitutes power. Any problem in the power leads to abnormal labor, like either poor uterine contractions or poor maternal efforts. Next, passenger. Passenger here is the baby. The baby should not be excessively large, or it may be in a wrong position. These two will cause abnormal labor. So passenger problem is another problem. Next, the problem in the passage. Passage means right from the uterus to the vulval outlet in the birth canal. Any problem in the pelvis or soft tissue abnormalities, all these will be dealt in detail. First, coming to the problem in the power. First, I have already told you both uterine contractions and maternal efforts are needed. Among the uterine contractions, if they are reduced, it is called hypotonic dysfunction. If it is excess, it is hypertonic dysfunction. That is basic. Among the hypotonic uterine dysfunction, it is more common. It is also called uterine inertia. Here what happens is basal tone is decreased, and how you can augment the poor uterine contractions is you can add an oxytocin drip through the normal saline. You put 1 ampule oxytocin for a primary gravida, 1 ampule oxytocin in 500 ml normal saline, and for a second gravida, half ampule oxytocin is added. That is 1 ampule oxytocin contains 5 units. So for a primary it will be 5 units oxytocin drip, and for a second gravida half ampule means 2.5 units oxytocin drip is added to augment the uterine contractions. Because more than that in second gravida it will be excessive uterine contractions. Always you have to remember, excessive uterine contractions are also dangerous. Hypertonic uterine dysfunction, here the basal tone is elevated. So what happens is because of the excessive hypertonic contractions, some contraction ring like that may form, and that will also obstruct the passage of the baby. And how to reduce this hypertonic dysfunction is you sedate the patient, give some analgesic sedatives so that she'll sleep and her uterus will relax a little bit. Next, what are the abnormal patterns of the power is, let's see, all of you know, normal labor is divided into 3 stages. Stage 1, 2, 3. Stage 1 is from the onset of true labor pains to full dilatation. This stage 1 is again divided into a latent phase and an active phase. Latent phase is onset of the true labor pains. True labor pains means patient should have regular uterine contractions. That is, some contraction relaxation should be alternating. It should not be continuous pain, will not be there. If it's true labor pains, there will be mucoid discharge, show will be there. That constitutes true labor pains. And from there to full dilatation, that is divided into latent phase and active phase. Latent phase is less than 3 centimeters cervical dilatation is latent phase. More than 3 centimeters, it is active phase. So coming to the disorders, the disorder in the latent phase is, it is prolonged, is called prolonged latent phase. The active phase disorders are protraction disorder, arrest disorder. This is nothing but protraction disorder means totally it is slowly progressing. Arrest disorder means totally there is no progress. Precipitate labor, this is an abnormality of the, that is where abnormality where it is the progression of labor is too fast. I will tell you in detail about this. First, coming to prolonged latent phase. Here, prolonged latent phase means latent phase lasting longer than 20 hours for a nullipara. Usually, latent phase will be approximately like you can rate it from 8 to 12 hours, and for a second gravida sometimes latent phase may last only for 6 hours, but prolonged latent phase means in a primary it may extend up to 20 hours, and for a second gravida it may extend more than 14 hours, and if it is more than 8 hours in a PARTOGRAM management protocol. PARTOGRAM will be dealt in later part. Okay, coming to see, you can see normally in prime is the latent phase is average is 6.4. That is, you take an average of the duration. In a second gravida it is 4.8, and when you call it prolonged is more than 20 hours in primary and more than 14 hours in a second gravida. Next, active phase disorders. I already told you, one is protraction disorder, another is arrest disorder. Protraction means slower than normal. Always in a primary gravida, if the cervical dilatation is less than 1.2 centimeters per hour, it is called a protracted disorder. And for a second gravida, less than 1.5 centimeters per hour, that is slower than normal, but not total arrest. Arrest is complete cessation of the progress. Causes, yes, one is it can be due to CPD, it can be due to uterine contractions, or both. See, this protraction disorder or the active phase disorder, it is taken in two terms, both in the cervical dilatation and the descent, both are taken into consideration. In a primary, if the dilatation is less than 1.2 centimeters per hour, and descent if it is less than 1 centimeter per hour, it is taken as protraction disorder, and that is it will last more than 8 hours. Multipara, if it is less than 1.5 centimeters per hour dilatation and less than 2 centimeters. See, second gravida it should be more faster. So if it is less than 2 centimeters descent per hour, and if it is extending, active phase is extending more than 5 hours, it is taken as a protraction disorder. Next, arrest disorders. That is totally there is no dilatation and no descent in a primary after 2 hours. After 2 hours, after keeping the oxytocin drip and giving all the augmentation things also, there is absolutely no dilatation, no descent. Then you take it as an arrest disorder. And for a second gravida, within half an hour, within 1 hour, you expect some amount of cervical dilatation and descent. If it is not present, it is taken as an arrest disorder. Next, coming to second stage. Second stage, already I have told you 3 stages. After the first stage, second stage is from the cervical dilatation completion. That is 10 centimeters dilatation, 3 to 10 centimeters dilatation is active phase. After that, second stage starts. From the onset of the full cervical dilatation to the delivery of the baby is second stage. That is, the expulsion part is the second stage. This incorporates many of the very necessary movements, very like the restitution, all these are required for the expulsion of the fetus. So any CPD, disproportion, fetal-pelvic disproportion, will lead to a second stage disorder. So in a primary, usually second stage makes you can, after full dilatation, you can wait for descent for up to 2 hours maximum. After that, you have to intervene. If the patient is under epidural analgesia, even 3 hours you can wait. And for a second gravida, maximum within 1 hour the baby should come, half an hour to 1 hour. With epidural you can wait up to 2 hours. More than that, then it indicates that there is a second stage disorder. It is, you have to intervene with cesarean section. And then coming to the another abnormality of the power is inadequate expulsive efforts. That is, the mother should aggressively bear down during the second stage for the baby to expel out. If she is having some, if she is exhausted, she is in labor from last night or something, and she did not have any even liquids also, she's exhausted, she stopped bearing down, that is leads to inadequate expulsive efforts. Then what you have to do, you have to assist the delivery. If it is zero stage, if it is the descent has not fully occurred, you have to assist the delivery by putting a forceps or a vacuum to deliver the baby. Next, precipitate labor. This is, I already told you, the here the it is faster than normal. That is the main thing. And in primary, always labor, normal labor, it should take the usual amount. It should not be too fast, it should not be too slow. If it is too fast, like in a precipitate labor, the main problem is the uterus. If it will be in a it will be very that contracted mode will be there, and after delivery it will lead to severe postpartum hemorrhage, precipitate labor. That is the main problem, and there may be very traumatic PPH, that too is more common, where any cervical injuries, vaginal trauma, trauma to the cervical lips are more common with precipitate labors. If see in primary, if the dilatation is more than 5 centimeters, see if for full dilatation you need 10 centimeters dilatation. If it is on a primary, it is dilating 5 centimeters per hour, means within 2 hours only the patient will deliver. And descent also, if it is too fast, multipara 10 centimeters per hour means from the onset of labor pain she is going to deliver within 1 hour. Such things are called precipitate labor. Next, how will monitor the power? External fetal monitoring. This is what the CTG is, what you see in the our labor room. Here CTG or external cardio topography, CTG. This trace is taken. There are two probes. These are tied, one at the fundus. This studies the uterine contractions. Cardio topography means this takes the Toco. Toco means uterine contraction pressure. That is traced here. This is uterine contractions. These peaks are the uterine contractions. This pressure is recorded as 25, 0 mm, 25 mm, 50 mm, 100 mm, like that. Usually in latent phase, it will be below 50 mm. There are three this whole trace is for 10 minutes. There are three contractions here. And this probe is usually, this is placed at the fundus area, and this is placed at the area where the fetal heart rate is heard. So usually in the left spino-umbilical line it is heard. So this records the fetal heart rate, and this fetal heart rate is recorded in this line, this graph. This is cardio, this is Toco, CTG, cardio topography. So here there are, if there are any increase of 15 beats more than the baseline, it is called accelerations. Here there are no accelerations. If there is decrease of 15 beats, there will be dips. Those are called decelerations. In this graph, there is no acceleration, no deceleration. This is like an equivocal sleep pattern CTG. Usually this trace comes in whether if the baby is in sleep mode, or sometimes if the baby is having some distress also. Here the patient, this is not in a sleep mode, the patient is having active uterine contractions. So maybe some fetal heart, some fetal distress is there according to this CTG. This is the printer, and here you can get the graph paper. Next, this is a CTG paper, and contractions are this one block is 1 minute. Contractions are measured from peak to peak. And if the also the decelerations, if this is the uterine contraction, and if you get the deceleration here at the starting of uterine contraction, it is called early deceleration. If it comes after the at the end of the uterine contraction, it is called late deceleration. If it is variable, it is called variable decelerations. All these decelerations are indicative of fetal distress that we have to intervene. Accelerations indicate that it is a good fetal heart rate. Baby is not in distress. That is the importance of CTG. Next, this is hypertonic dysfunction. Here you can see more than 5 contractions in 10 minutes. Excessive uterine contractions. Next, feto-pelvic disproportion. This occurs due to any the problem in the pelvis, problem in the fetal size, or in the fetal position. Two types of CPD: absolute and relative. Absolute means this will be present. You cannot. There is no chance for a trial labor here. It is again the contracted pelvis or a very big baby, macrosomia more than 4 kgs, more than 4.5 is macrosomia. Relative CPD means malpresentations, that is occipito-posterior like that. It may rotate to anterior during delivery. It is relative. And a tight perineum, tight perineum also with good augmenting agents, it may deliver. Next, contracted pelvis. All you know, there are three dimensions of the pelvis: inlet, mid cavity, and outlet. First, the problems in the inlet are if the AP diameter, shortest AP diameter less than 10, or greatest transverse diameter less than 12, or diagonal conjugate less than 11.5 centimeters. Diagonal conjugate means from the sacral promontory to the pubic symphysis. It is taken from the and the measurement is taken. If it is less than 11.5, then the baby, it is difficult for the baby to deliver. Then problem in the cavity, mid pelvis. This is more common than inlet contraction. This causes transverse arrest of the fetal head. Cavity means both sides ischial spines are the main obstructing things. If the interspinous diameter, it should be at least 10 centimeters for the baby to deliver well. If it is less than 10 to less than 10 centimeters or less than 8 means it is severely contracted cavity. And if the spines are prominent, and if the side walls should be either parallel or diverging for the baby to come out. If it is converging, it is difficult to come out. Then if the sacroiliac notch is narrow also, it is a contracted pelvis. Then at the pelvic outlet, the ischial tuberosities, both the sides will be there. No, intertuberous diameter is taken. If it is 8 centimeters or less, then it is a contracted outlet. Next, we have talked about the bony part problem. About the this is all power is finished. Now we are talking about the passage. The bony part is over. Now the soft tissue problems. It can be pelvic masses or the placental problems. Pelvic masses are carcinoma of the cervix, lower uterine segment fibroid, distended bladder, ovarian tumors, low-lying placenta. May all these will prevent a fetal descent. Next, pelvic mass. This is a picture of a pelvic mass. See, this is all the pelvic mass. So this is obstructing the descent of the baby. See, this is also a picture of the mass preventing the obstruction of the, preventing the passage of the baby, causing obstruction. This is a low-lying placenta. Placenta usually should be implanted at the fundal region. If it is implanted here in the lower uterine segment, it will if the baby tries to push down, There will be only bleeding, but the baby will not come down. This is an indication for cesarean section. Placenta, if it is low lying, it is called placenta previa. Okay. Next, power passenger passage. Next is the passenger. Passenger problem is fetal dystocia. It can be caused either by the problem in the position or presentation, or problem in the size, excessive size. Malposition or malpresentation is the most common cause of fetal dystocia. Coming to your malpresentations already is being dealt, I'll just give a briefing, that's all. Face presentation means or the most common present the most the presentation which leads to normal labor without any difficulty is vertex presentation, where the head is flexed. If any deflection is there or hyperextension is there, all these will cause problems. In face presentation, head is hyperextended. Occiput, like it is head is hyperextended means occiput is contact with the back and the chin becomes the presenting part. In a vertex presentation, it is suboccipitobregmatic, whereas in face presentation, the presenting diameter is submentobregmatic. That is from the below the chin to the anterior fontanella. It is 10.2. Next, bro presentation. This is the portion of the fetal head between the orbital ridges. That is, orbital ridges means the place where eyebrows are there. That is called the orbital ridges. Ridges from there to the anterior fontanelle. If this is the presenting part, then it is called bro. Bro area is the presenting part. This also it may not convert to vertex presentation. Usually this also may lead to cesarean section. Here in this picture, you can see this is the face presentation and the chin is the presenting part. So this have excessive molding has occurred and the presenting diameter is submentobregmatic. That is below, mentum means chin, below the chin to anterior fontanella is also called bregma. Submentobregmatic, 10.5. This is the bro presentation. This is the bro part, that is from the orbital ridge to the anterior fontanella. This is the presenting part. And it is next transverse lie. Transverse lie means lie. What is lie? The relationship of the longitudinal axis of the fetus to the longitudinal axis of the mother is the lie. If it is usually longitudinal lie will be there, the other things are oblique lie and transverse lie. If it is parallel, the long axis is parallel to the long axis of the mother, it is longitudinal lie. If it is perpendicular to the long axis of the mother, it is transverse lie. If the long axis is oblique to that of the mother, it is oblique lie. So here transverse lie means long axis of the fetus is perpendicular to that of the mother. Incidence is 0.3%. The transverse lie always usually comes with a shoulder presentation. The shoulder will be there at the pelvic inlet. And how can the shoulder, see for an vertex presentation, you call it the occiput is taken as the denominator. So for a shoulder presentation, acromion is taken as the denominator. And if it is lies on the right side of the maternal pelvis, it is right acromion. Left side, if the acromion is facing left side of the maternal pelvis, it is left acromion. So this is a picture of the transverse lie. See, the long axis of the mother is this and the long axis of the fetus is perpendicular. So in the shoulder, usually shoulder presentation will be there, and sometimes an extremity may come out, a limb or leg or a hand, not leg, hand. This has led to obstructed labor, and here a pathological retraction ring is formed. This is called Bandel's ring. This ring will obstruct the fetus to come out. Next, compound presentation. Compound presentation means not one part, two parts are presenting at the pelvic outlet. Uh, so that means an extremity, either a hand or a foot is all presenting along with the head like that. That is called compound presentation. That also is difficult to deliver. A condition that prevents complete occlusion of the pelvic inlet by the fiddle head. Persistent occipito-transverse. See, this occurs in the case of an occipito-posterior position. The occiput should be on the anterior side of the maternal pelvis. If it is posterior, it is called occipito-posterior. This usually 80 to 90% of them, during the process of labor, they convert to first occiput transverse and then occiput anterior and comes out. If it stays persistently in the occipito-posterior, it delivers as phase 2 pubis delivery. That is also, it is slightly difficult, but it happens normal delivery. But if rotates only to occipito-transverse from occipito-posterior and stays there in that position, it is called deep transverse arrest that cannot deliver normally. You have to do a cesarean section. Causes are pelvic dystocia, uterine dystocia, platypelloid or flat pelvis, android pelvis. All these, the occipito-transverse, deep transverse arrest is common in platypelloid and android pelvis. Occipito-posterior position. Occipito-posterior deliveries are more common with anthropoid pelvis. This is a PG entrance bit. Occipito-posterior for anthropoid pelvis. Deep transverse arrest for android pelvis. Next, shoulder dystocia. Shoulder dystocia means always after the head delivers, the shoulder also, that is the body, we should deliver within the average of 24 seconds. If that head to body delivery time is exceeding 60 seconds, it is called shoulder dystocia. There are various maneuvers. Causes already, you know, main problem is macrosomia. Big size of the baby is the main problem for shoulder dystocia. The failure of the shoulders to spontaneously traverse the pelvis after delivery of the fetal head is called shoulder dystocia. There are various maneuvers, and the main cause I have already told you for shoulder dystocia is macrosomia, more than 4 kgs baby, and this is more common with gestational diabetes, mother having diabetes. So with the shoulder, what happens is with shoulder dystocia, now there will be umbilical cord entanglement. Cord may get entrapped, and the inability of the child's chest to expand properly, severe brain damage, baby may develop later cerebral palsy, and then brachial plexus injury may lead to Erb's palsy. After the day baby comes out, if you pull it too hard with all the maneuvers, baby may come out, but the brachial plexus may get stretched or may be torn. If it gets stretched within immediately, the baby can't move that hand, but after 2-3 weeks of physiotherapy, the baby will recover. But if the brachial plexus gets torn, means then you cannot repair it. So that is the problem with shoulder dystocia. Here you can see the brachial plexus injury has occurred. So see, you can, hand is lying, the baby cannot lift the hand on the side where the brachial plexus injury has occurred. So all these should be taken account. So that's why better not go for a normal delivery in a 4 kgs baby. Next, breech presentation. I already told you, they are clinical classes. Presentation means the part which is present at the lower pole of the uterus is called presentation. If the head is below, it is cephalic presentation. If the buttocks is below, it is the breech presentation. Like that, it is face, bro, the various things, footling presentation, knee presentation. So coming to this is breech presentation also an important cause of the fetal dystocia. When the fetus assumes a longitudinal lie with the cephalic pole lying at the uterine fundus and the caudal pole at the pelvic brim, caudal, or this is also called caudalic pole. This lies at the inlet. It is called breech presentation. The buttocks enter the pelvis first. Just a description of the various types of breech. Complete breech means this is flexed both at the hips and at the knees. It is flexion is there in either part. So presenting part will be the buttocks and also feet. Next, incomplete breech, frank breech. Frank breech is also called breech with extended legs. This is, there will be flexion at the hips, extension at the knees. So it is also called, here the presenting part will be only buttocks, feet will not be there. Here the presenting part will be buttocks and the feet. Incomplete breech, this can be if a knee presentation may be there or a footling presentation may be there. That is if it is extended at the knees, it will be a if one, here you can see this leg it is extended, this leg it is here, this knee is flexed, so it may be a footling presentation. Next, why these presentations among the breech also, why you're looking for the all these presentations is vaginal delivery is occurs in the frank breech. See in the previous slide, frank breech means only buttocks. Now nothing is obstructing here. Breech with extended legs. Here the normal delivery is easy. It is possible. So the main indications for vaginal delivery in breech are no other indication for cesarean section like diabetes, hypertension, or any other problems. No macrosomia. Weight should be less than 3.5 kgs. Frank breeches, breech with extended legs. Pelvis should be good. Adequate gynecoid pelvis. All these, then the score will be more than 4. And also in a breech, if it is big size or any problems also, but if there is, it is an anomalous baby, then even though it is a breech, if it is an IUD like intrauterine death, you can try for a normal delivery. And also if the mother has come in active labor, then also you can go for a normal delivery. Otherwise, go for a cesarean section in a breech, that is better. Otherwise, the main problem comes with breech delivery is the legs, buttocks, feet, legs, shoulder, hands, everything will be delivered, and at the level of the head it is more difficult. Head gets entrapped at the inlet, and the head, if the delivery time exceeds more than 1 to 2 minutes, there may be hypoxia and baby IUD may occur. So breech delivery, it spontaneous means totally it has delivered spontaneously without any efforts of the nothing, no doctor has intervened, spontaneously it has expelled out. Extraction means always if you assist the delivery of the baby. The doctor assists means then it is called assisted breech delivery. Among them, partial extraction means the buttocks and feet expel spontaneously. From there you intervene, it is partial extraction. Total extraction means you put your hand inside the pelvis and remove one leg, both legs one by one. That is called total extraction breech delivery. The maneuvers for breech are Marshall Burns, Morrisselli's smelly wheat maneuvers that is already dealt with, I think. These are the maneuvers for delivering the babies. This is actually not for breech. This is for shoulder dystocia, Wood's maneuver and McRoberts maneuver. McRoberts means you hyper extend, that is you ask the legs are pulled on to her stomach. so that this diameter increases and the shoulders come out. This is Wood's maneuver. The hand is placed behind the posterior shoulder and shoulder rotated 180 degrees in a corkscrew manner so that the anterior shoulder is released. These are the maneuvers for the shoulder dystocia. Breech, I didn't get the pictures. Next, fetal malformations. Fetal malformation is also a cause for fetal dystocia. Now, until then, we are reading about the problems in the pelvis. Pelvis, that is the problem in the passage. Sometimes baby also may have a tumor, either in the head, hydrocephalus, and or in the abdomen. All these will cause obstruction in the labor. This is a picture of the hydrocephalus. This is also obstructing the delivery of the, usually in hydrocephalus, breech will presentation will be there. So in this picture you can see baby has delivered up to the shoulders and head is not coming out. Next, how you assist in the delivery process is, if there is any, it may be a problem anywhere in the power passage or passenger. If it is a relative problem, you can go for an assisted operative delivery. Here you are applying an forceps. These are the two blades handle, and you apply at the both the biparietal here at the both parietal eminences, the both blades are applied, then the forceps blade is locked and the head is removed out. It is forceps delivery. This is vacuum, or vacuum is also called ventouse. Vacuum delivery is also forceps vacuum, both are assisted instrumental deliveries. These come under instrumental deliveries. You have with the suction pressure, the one, it is called chignon. This is formed at the scalp, and with that pressure head is removed out. The advantage is with this vacuum, there will be no maternal injuries, no maternal trauma, but the trauma will be only to the fetus. Whereas with the forceps, there will be more trauma to the maternal tissues, but fetus will be fine with forceps deliveries. There may be some markings may occur if you don't properly apply the forceps, or if the position is not correct. But with what happens with vacuum is, fetal intracranial hemorrhages chances more with vacuum. Next, after all the options, the only option left is cesarean section. I think this was dealt in the previous class, detailed. Next, this is management of abnormal labor. The concluding part is, the main part is the partogram. This is very important. Partogram, what is partogram means? It is recording the progress of the labor. Like you CTG, I have already told you, CTG means recording the uterine contractions and only the fetal heart, only those two are recorded. This partogram means this is not done with any machine, only this is a graph, like a graph, and we will be writing all the details. Those who are on duty sister or duty house surgeon will be recording the partogram. Why it is important to record the progress of labor is to provide continuity of care. See, normal delivery, sometimes it will last 8 to 12 hours, sometimes 24 hours or more than that. So continuity of care, morning shift one doctor will be there, afternoon another shift, night one. So we cannot completely hand over all the details of the one patient. There will be some 50 patients. We cannot continuously hand over every detail. Some mistakes may be there, so that lack, that any problem in that handing over will may cause a problem to the mother. So this partogram has been discovered to rectify all those problems, to help in decision making, to provide continuity, and to defend one's actions. It is also proof, a documental legal proof. If any patient, if they sue us that we have not monitored her properly, if the later the baby IUD or stillbirth occurs, they will they will sue us that you haven't done cesarean section at the right time. If you had done cesarean, the baby may have saved. So to avoid all that, this is like a document, a proof of what you have done during the, how you have monitored the labor. Next, PARTOGRAM is a graphic definition, is a graphical information about the progress of labor, in which the salient informations about the fetal well-being, maternal well-being, and the progress of labor are recorded into a chart. Why it is significant? It is a managerial tool used to record all the observations made on the woman and the fetus in labor in one chart. It helps to identify at an early stage those women whose labor is slow. Just looking at the PARTOGRAM, you can say whether the labor is progressing normally. It can continue to wait, or you have to intervene and do cesarean. Just on looking on the graph, you have to get an idea. That is the advantage of PARTOGRAM. And WHO recommends PARTOGRAM monitoring for all women in labor, either low risk or not only high risk, means diabetes, PIH, twins, breech, anything. But the WHO recommends PARTOGRAM monitor. PARTOGRAM sheet should be in the case sheet of all the patients in labor. Friedman's PARTOGRAM. Here, the two phases of labor, I have already told you. One is latent phase up to 3 centimeters dilatation, active phase. This is all active phase. And Philippot and Castle introduced the concept of alert line and action line. I will tell you detailedly everything. Alert line means the mean, this is green line is the alert line, the mean rate of the slowest progress of labor. Anything, if the graph is the whole entire graph of the dilatation and descent, if it stays before this green line, then the labor is progressing good. If it is between the green and blue, you have to be cautious. If the graph has crossed the blue line, then you have to go for a cesarean section. This is alert line, this is action line. Usually the normal labor should be plotted to the left of the alert line. Everything should be in this part. So what are the, you have to monitor what are the points are. First, mother information, name, age, address, fetal well-being, fetal heart rate, liquor, moulding, labor progress, dilatation, descent, uterine contractions, any drugs you have given, oxytocin. Here you can see in the chart it is there, oxytocin, pain relief with pethidine, maternal well-being, see, BP, pulse recorded here, BP pulse, temperature is recorded 96, 97. Then any urine test if we have done, urine albumin, acetone, glucose. Then here urine output 200 ml, 180 ml, like that output. This here is cervical dilatation and descent are plotted here. Fetal heart rate is plotted. This is like our CTG, fetal heart rate. This is uterine contractions are plotted here. Oxytocin is plotted here. What need to be recorded? So you always plot is begin plotting at the 0 hour. All entries should be made in relation to the time. Each note should be legible, date and time should be there. And what was the outcome? Either it went into normal delivery or went into cesarean or forceps or vacuum. The outcome should be documented. Mother information, right here, the name, age, see, Mrs. name, gravida, para, hospital number, IP number is, then the just date of admission, time of admission, membranes ruptured or not, at what time, then a short antenatal history. If she is having GDM or something like that, you have to mention it. Then fetal heart rate, membranes, amniotic fluid. See, amniotic fluid is monitored like this. If it is C means clear, then R, M means meconium, like that. Any moulding is present, it is mentioned. Fetal heart monitoring, already I have told you how they monitor the contractions. Good means 2 to 3 contractions in 10 minutes. amniotic fluid intact. If the membrane is not ruptured, you write here I. If ruptured, clear liquor means C. If meconium, M. If there is no liquor, write it as A. Molding of the fetal skull. This provides information about the pelvis. If there is excessive molding, means pelvis is not good. That is the main thing. There is fetal disproportion. So if the bones, the fetal bones are separated, it is 0 or no molding. 1 plus means the bones are scalp bones are touching, but they're not separate, can be separated. 2 plus means the overlapping of the scalp bones of the fetus is present. 3 plus means the bones have overlapped severely, cannot be separated. Severe molding means 3 plus. Labor progress is here, cervical dilatation and descent are monitored, and uterine contractions are also monitored. Dilatation of cervix is plotted as X, descent as O. Plot dilatation, how you will plot it as dilatation as X, descent as O. So here dilatation at admission, if the dilatation is 2, here this is 0. So if dilatation is 2 centimeters and descent is -2 station, that is it is 2 centimeters above the ischial spines, then descent is called -2. It is plotted here. 2 hours of the after admission, if the descent is -1, descent is 0. So it is slightly decreased from -2 to -1, and also dilatation, it is same, only 2 centimeters. So until the dilatation is comes into 3, you call it in the latent phase. Active phase, it will be dilatation for at 2 hours, it will be usually 4 centimeters, at 4 hours 7 centimeters, at 6 hours 10 centimeters. Descent will be -2, -1, 0, +1, +2. +2 means or later than it will be expelled out. If the labor is progressing well, all this plotting of cervical dilatation, that is X, cervical dilatation in X, will be remaining to the left of the alert line. If it crosses to the right of the action line, then it indicates the labor is prolonged. Uterine contractions. This is uterine contractions. How they observe, one square is 1/2 an hour, and if it is the uterine contractions, then if they are lasting less than 12 seconds, it is plotted in like this. It is 20 to 40 seconds, slightly dark. The more than 45 seconds strong contractions, it is plotted as shaded as black. Okay. Here you can see, here the contractions were weak, then become mildly strong. Here they have become strong. Mother things here are BP pulse are recorded here. BP pulse, urine, acetone, glucose, urine volume. If progress is satisfactory, the plot, this is already I have told you. So just few patterns. This green dotted line is the normal labor. As you can see, all the descent dilatation, everything has been on the left of the alert line. This is alert line. Prolonged latent phase. This has crossed the action line. Primary dysfunctional labor. This is in between alert and action line. Secondary arrest. This purple color is the secondary arrest. So this partogram is very important in monitoring the labor. This helps in, so all these things, why you are so worried, you have to give a healthy baby to the mother. That is very important. All these monitoring will help you in case if there is any flaw in the progress of the labor. Thank you.